All right. Hello, everyone. Thank you again to Vicki and Colin and Liz for that fantastic panel. It is now my honor to welcome our second slate of panelists this afternoon for our Stakeholder Insights Navigating the Future of Health Policy. For our next panel, I'll welcome to the stage Tanisha Carino, a partner at Brunswick Group and the former chair of the Alliance for Health Policy Board of Directors. Tanisha will moderate this discussion. Tanisha provides strategic counsel to healthcare organizations on a variety of issues spanning public affairs, organizational design, issue management, and stakeholder engagement. She joined Brunswick with over 20 years of experience in various leadership roles across government, private, and nonprofit sectors. Tanisha served as the inaugural Chief Corporate Affairs Officer at Alexion, Executive Director of Faster Cures at the Milken Institute, led U.S. public policy initiatives at GSK, and headed life science and strategic advisory services at Avalere Health. Tanisha is also a Fulbright Scholar and has served as visiting fellow at the White House Office of Science, Technology, and Policy. Tanisha, I'm going to keep going. Tanisha earned her Ph.D. in health policy from Johns Hopkins University and is currently associate faculty at the Johns Hopkins Bloomberg School of Public Health. You go, girl. Joining her on stage is David Merritt, the Senior Vice President of External Affairs at the Blue Cross Blue Shield Association. David leads legislative, regulatory, political, and communications initiatives representing Blue System companies covering 1 in 3 Americans. With more than 20 years in health policy, politics, and public affairs, he has been recognized by The Hill and Washingtonian as one of Washington, D.C.'s most influential leaders. Before joining the Blue Cross Blue Shield Association, David was Executive Vice President of Public Affairs and Strategic Initiatives at America's Health Insurance Plans, where he led major advocacy campaigns and a national rebrand. Earlier, he led the Washington office of Levitt Partners, advised 3 presidential campaigns, and served as CEO of the Center for Health Transformation under Speaker Newt Gingrich. Next up, we have Randall Rutta. Randy is the Chief Executive Officer of the National Health Council, where he leads efforts to unite diverse organizations in advancing patient-centered, high-value health policy. A senior health executive with more than 30 years of experience, Randy has dedicated his career to translating policy into practice and driving health system improvement. Before joining NHC, he served as president and CEO of the American Autoimmune-Related Diseases Association and previously led Easter Seals, where he oversaw advocacy, policy, and service programs for people with disabilities, veterans, and their families. Randy holds a Master's of Arts in Politics from the Catholic University of America and a Bachelor's in Sociology from the University of Minnesota. And finally, I'd like to welcome Debbie Witchey to the stage. Debbie Witchey is the president and CEO of the Association for Behavioral Health and Wellness, a seasoned association executive with deep expertise in government affairs, stakeholder management, and healthcare policy. For more than 20 years, Debbie served as executive vice president and chief operating officer of the Healthcare Leadership Council. At HLC, she managed operations, guided legislative and regulatory initiatives, and directed nationwide grassroots efforts to advance priorities such as access, coverage, and population health. Earlier, she built an award-winning community health program for a Charleston hospital system and served as Deputy Assistant Secretary at the U.S. Treasury Department under both Republican and Democratic administrations. Debbie holds a master's degree in health administration from the Medical University of South Carolina and a bachelor's degree from Duke University. Tanisha, the stage is yours.
Thank you, Kelly. And as Kelly said, I'm your moderator today. I'm delighted to be with Randy, Debbie, and David for this conversation that's entitled Stakeholder Insights and Navigating the Future of Health Policy. This panel is a little bit different than the rest of the panels today because it was really brought together by the Alliance's ambassador-level sponsors for this event. And as a former board chair and a member of the Emeritus Council, I'd like to thank you as well for your support of the event. Now, you'll be hearing from each of our panelists more of like a view from the ballroom, but really each of them are long-term Washington policy experts and come from different perspectives. And really I'm excited to hear from you all where you see the health policy world going in 2026. And specifically, really reflecting on some of the Alliance's signature programs that we've had over the last 10 years. Some of the recent topics, as many of you all know, have been on aging, AI, person-centered care, and even mental health. So for those of you who know the Alliance, you'll hear us come back to these topics throughout this discussion. And I invite the panelists to not only share your perspectives, but really dialogue with each other as well as we go on today. So for the first question, the Alliance is about to celebrate its 10 years of our annual Signature Series programs. And like I said, past sessions have been most recently on AI, mental health, aging, as well as person-centered care. When you think about these topics, do any of these topics really stand out to you for being top of mind going into 2026?
I'm happy to kick off. I'd first start by just thanking the Alliance. This has been a great partnership, a longstanding partnership for BCBSA, and in particular this year has been great. So really appreciate the opportunity to be here. Those are all great topics, and I think they're all very timely topics. The one I would point to is aging. I think we all know the demographic trends. People are living longer, and more people are living longer. And we need to make sure that as we age, we have the support and the health care that we need as we age. And so Medicare Advantage is a really important part of that discussion, and I think a really important part of the solution. When you compare Medicare Advantage to fee-for-service, it delivers better value for the dollar, better benefits, better clinical outcomes than fee-for-service. It actually covers more low-income Americans than fee-for-service, and actually covers more seniors and people with disabilities who have higher healthcare needs. And I think over the 20 years that MA has been in the marketplace, it has a proven track record of delivering real results. And actually, if you just look at what CMS put out last week as far as premiums go, it's one of the few premiums that we actually seen go down, with the average premium next year of only being $14. So delivering really solid benefits, integrated benefits. We know that it's a real part of the solution as America ages, and we need to make sure that it's strong and stable for the long term.
Great. Thanks, Deb. Thanks, David.
Well, I'll take the behavioral health question, partly because of where I work, but also because I do think it's an important issue. So just a little bit, the association is made up of health plans that provide mental health and substance use disorder benefits to about 200 million Americans. And so that's really our area of focus. And I think what we've seen particularly since the pandemic is a recognition that behavioral health is important to overall health. So I think a couple of things. We've got more and more young people coming up through the into the system who are demanding better mental health and behavioral health services. But even more important from my perspective is this interrelationship between behavioral health and physical health in essence. And I was talking to someone a couple of weeks ago about orthopedic surgeons, and I guess more and more of them, as I understand it, are starting to add behavioral health specialists into their practice because of the understanding that so much of what people undergoing orthopedic procedures are experiencing has a mental health effect as well, and making sure that that's addressed. And that's just one example. So as I look into next year, I think we're going to see even more and more focus in this area. We're going to see more interest in integration. And we're also in the substance use area, which is part of behavioral health, but I think specifically really wanting to see more information on outcomes and understanding where to go to make sure that you're really getting quality care. For a long time, particularly during the opioid crisis, it was really about access. And access, of course, is important, but I think a lot of that has been solved. But now it's sort of access to what, and access to a program that's really going to make a difference for individuals.
That's great. Thanks, Debbie.
Great.
Randy?
Great, thank you. Well, it's great to be here. Thank you to the Alliance, and thank you for all of you for participating in this conversation. So coming from the National Health Council, where we represent almost 200 national organizations, the majority of which are patient organizations, all of those areas, Tanisha, I mentioned, you really resonate with me. You know, our purpose started more than 100 years ago is to make sure that patients have a voice in their health care, and that it's meaningful and it's respected. And so being person-centered, patient-centered, which is one of the areas that the Alliance really has made a part of their work, really resonates with me. But the area I'll just touch on briefly is something I've been spending a lot of time on really the last 2 years, is a dedicated effort to support the patient community in managing their personal health, but then also our patient organizations is being on the front lines of 21st century medicine and healthcare and support, and that's the AI space. And I think the previous panel really touched on how emerging technologies, digital health, and AI really is transformational. And for the patient community, we saw the writing on the wall, as everyone did, and seeing AI emerge as something that's transforming society, transforming we interact with all the parts of our lives. And I know each of you has had a voice in that space. And we wanted to make certain that for patients, they were included, that the kind of AI and the kind of technology that was emerging really did speak to their needs in a way that recognized, and for them to recognize that, hey, this chatbot understands me. It's speaking to me in a way that is respectful of my culture, my proficiency, my healthcare issue. And so we really moved forward to make sure that for the patient community and for our patient organizations that we understood this transformation that was occurring. We understood the language that was being used, the issues that were being driven, the private and public sector roles that are really advancing this, so that we could be best partners in that journey. And I think as the Alliance was an early convener on this topic, really pointed out, it is a learning journey. It's a learning journey for policymakers. It's a learning journey for those innovators. And it's a learning journey for all of us then that are affected by the tools, the techniques, the information that's coming forward. The primary goal was to make certain that as AI emerged, patients were not marginalized, but were at the center of that consciousness, because it is health AI that we're focusing on. And then also making sure that the data set that these algorithms are being trained on actually is reflective of patients, because right now that data set's either pretty inadequate or really siloed. But how does that data set that may skew toward people who are, from a certain ethnicity, from a certain age group, really reflect the experience of kids, the experience of people who are older, people who are in diverse cultures or in different parts of the geography? That was a huge part that really drove us toward that, so that it was accurate information, pushing out misinformation, can ensure that those algorithms, as they address problems in healthcare to help us do better in getting to the health outcomes that were meaningful and systems change that's better, would truly be reflective of the population we're looking to help. So that would be one thing I would call out.
Well, what a great start. I mean, you guys have hit on every single topic that we've focused on the last few years, and I think hopefully that was intentional too. But I will also say that it feels like, whether it's AI, or whether it's the role of Medicare Advantage, also what we're reckoning with in terms of serious mental illness in the country is substance use. Like, we're at an exciting time in health policy to really not only be incremental, but really transformative in how we think about the next 20 years, not just in 2026. I want to go back to aging. I think aging is, I'm 50. I just went to visit my parents. They're aging, they're hitting their 80s. I think all of us with parents that were 70, they're doing great. 80, you're like, whoa, what's happened here? And so this aging conversation is, I think, near and dear to a lot of people's hearts right now. And whether or not we're prepared for what we've known for a long time in terms of that demographic shift is really critical. So this year, as you all know, the Signature Series focused on aging. And when we asked healthcare executives what they thought they needed in terms of innovation, and then where policy can actually support the needs of what we see in terms of the aging population, really for us, one of the questions that continuously comes up is, when you think about the not tension, but the synergy that could be between innovating to actually meet the needs of a population and the role of policy, what do you think about in 2026? And, if you had to have one wish for where you think policy innovation can happen so that we can take what we know works and actually bring it to scale, where would that be?
Well, I would say in having more interoperable systems, in really being able, if we're really going to be able to move forward, and I think about when you brought up the aging community, it's hard to navigate the system. It's hard even when you're not aging. But making that, and there's some real, I guess I'm jumping ahead to the next question you might ask us, but I'll bring it up now. There's some real bright spots that we're seeing where that is working better in oncology, in nephrology, and a few other areas where you really see an intentional effort to integrate that care and make it work better. And it's all based upon having really good interoperable systems. Again, from a behavioral health standpoint, the behavioral health community, partly of their own making and partly not, was left out of the High Tech Act when money was put forward to create EHRs. And so that community is playing some catch up, and there is, there's always some tension in making sure that privacy is protected in that area, probably more so than anywhere else. But for us to really move forward, I think patients are demanding it. Randy and I meet up every so often for breakfast and talk about these things, and he reinforces to me this is true. Patients are really pushing to want to have a more seamless care delivery, and I think it's up to us, and I think that to deliver that better, and I think it's something that we're going to see next year. And part of that too is about efficiency in the system.
Yeah.
We can't, there are lots of conversations about affordability and cost going on, as we all know. And part of that is about how do we make the system work better and save some money, but have better outcomes. Right.
Yeah, absolutely. Randy, do you want to jump in?
Just build on Debbie's statement. I think as I think about, our constituency, aging is very much top of mind at any age, because you're either kind of grappling, as you said, Tanisha, with maybe issues that are starting to affect you and your own, participation in the world, but then also for your children or for your grandchildren. So really, it's something that's multi-generational, but within the context of health policy, I think for the National Health Council membership, it's kind of twofold. One, understand the whole person. Make sure that we're really looking at a person who's growing older in the course of all of their needs. So I think what David mentioned about Medicare Advantage and really looking at how can chronic conditions and disease be managed? How could we, get out in front in terms of prevention? Those are the things that we're really excited about. And I think the conversation right now on Capitol Hill with the administration focusing on chronic disease prevention and management, thinking about nutrition and the role that plays in health. So for someone who's getting older, we would encourage you to think about not just that episodic interaction, maybe more than episodic, maybe it's quite often engagement with the health system relative to specific health needs, but then also support people who are aging more holistically. Is the housing appropriate for them? Can they access transportation? Do they have access to food and nutrition that's going to support their health? So that holistic supportive goal set in the Older Americans Act and kind of those decades-long planning sessions are going to be key. The other component part of the aging community conversation in healthcare generally is the role of family caregivers. This is National Caregiver Month, and it's not just that individual who's getting older in isolation, but how is their family supporting them, and how are they interacting with their family and pursuing their health? And then that investment in prevention. And I think that is an area where we could have realize such opportunity, or an opportunity to realize such gain, both in terms of healthcare system effectiveness, efficient management of resources, if we invest in people early enough to be healthier in the first place. And I think for the aging community, who are oftentimes experiencing multiple chronic conditions, managing crises and things, I think a lot to be learned from Medicare Advantage and the experience of the plans that have had chronic condition management and disease management programs in place for a long time. This is the year next year for us to bring those pieces together, and I'm excited for what that means for people who are growing older.
Yeah. And David, I want you to be like the last one on this, but when you think about 26, what is the most important policy innovation that we should be looking forward to, or what's the window that we should all be watching for?
Yeah, it's a great question, and the setups and the comments were spot on. Debbie, you mentioned affordability. We all know that we have an affordability crisis. No matter who you are, whether you get coverage through an employer, through a public program, or on your own, seniors are the most cost-conscious, one of the most cost-conscious demographics. So even small changes to seniors on a fixed income can really be a detrimental change. So what we hope we can do, looking at innovation and policy making, is actually drive some of these innovations that address cost containment and address reducing costs. Randy, you mentioned just a few of the benefits of AI. I mean, you look at some of the technology out there that can improve these manual processes. I mean, we spend more than $5 trillion a year. There are a lot of cumbersome processes that we can streamline through technology and innovation. Allowing policymaking to allow that to grow, I think, is important. Having guardrails so it doesn't cross any red lines and is actually a positive contribution is important. But allowing that technology to solve those problems, I think, is important. On the clinical side, having technology that can actually accurately and more quickly diagnose and treat problems. I mean, the opportunity costs that we pay when we don't have innovation to treat quicker and more accurately, we pay not only in health, but we pay financially. We all pay for the 2 or 3 treatments that don't work.
And the time.
And the time. I mean, there are so many costs that we pay that technology and innovation, I think, can bring solutions to the table. But Debbie hit on, I think, one of the most important ones, and that is just clinical data exchange. The more data we have, the more we can understand, the more we can know, and the more problems we can actually solve. And, you know, I've been around long enough that we've been talking about interoperability for literally for decades.
Right. Yes.
There is so much more progress that can be made to connect providers when there are handoffs, to connect payers with providers, and that data exchange really can be such a breakthrough on the innovation side that I think it can unleash a lot of positive solutions.
If you guys don't mind, like moderator's prerogative here, I think, we've been talking about interoperability for, I don't know, last 15 years, and we have this excitement with AI. It's almost like this AI is going to solve everything. And, we've recently at Brunswick done a lot of work to think about the perceptions around AI, and particularly around older Americans. There's still a lot of fear. There's this fear of like, what does this actually mean? How do we bridge the divide between helping people understand the potential, but having the right guardrails? Because I think from a policy perspective, we know where to go. But David, as you know, things are not always won on great ideas. Some of it is how do we talk to the public about this?
Yeah, I think that's an interesting point because a lot of what we hear in just society in general is, fake images and AI and, stuff that deep fakes. I mean, there's a lot of negative stuff that we see about AI, and it's almost like the nightly news. Like we hear about all the train wrecks and the car accidents. We don't hear about the positive applications of AI. So I think you also have to realize we've only been in this kind of, AI first phase for just a few years. I mean, there is so much more to learn. There's so much more to deploy. So I think that as providers and payers implement, AI that can actually deliver better solutions and solutions to big problems, I think we will have those positive stories. Yeah. The thing that I would, just from a policy perspective, make sure that we don't do is have a patchwork of state and local and federal rules that pull us in every different direction, where you have, really strict guardrails here and you can't do this, you can't do that, but over here it's the Wild West. Right. And you just have this patchwork of compliance that is impossible to figure out, for one, but also to deploy the technology. So that's one thing that we've talked with policymakers on, both at the state and federal level, is just to make sure that these are aligned so the technology can grow in a way that's positive and scalable.
That's great. Well, DC is oftentimes accused of admiring the problem. And I think this panel has done actually a really amazing job at really already talking about where are the bright spots. And I'd love to hear from you all. It doesn't have to be about aging. It could be about anything. When you think about what you're seeing out there in the world where you're like, oh, wow, this is amazing. And there's a role of policy to bring it to scale. Like, I'd love for you all to have the opportunity of sharing with that audience what that looks like, the oh, wow, but also what's that policy solution that helps us scale?
Why? You want to go?
I'll just jump in because there's kind of an intersection. So, we were talking about AI and the role that can play, and I think for Blue Cross Blue Shield Association, for AHIP, for others, all the members of the plans, that really embraced in collaboration with CMS and others, looking at how can we make prior authorization, which has been a way in which insurance has made sure that the kinds of services that an individual is receiving in their health plan are appropriate and medically necessary. There's a whole protocol to follow there. But really looking at, well, what's the role of AI in that space, and how can we make sure that the commitments that are being made, one, don't substitute a human in the loop for a purely data-driven, math-driven response, but then also how can we make sure that those systems are best empowered? I talked about the quality of the data that's there, and really drive toward change. We know that a lot of people, and we were talking about older people, are interacting with their healthcare system all the time. So if we design these systems in a way that really understand what are their questions, how do they want to receive their answers, actually those engagements become very positive interactions with the healthcare system, and they report, really feeling very good about that. We see something similar in ambient listening. That's probably an area where AI has been applied in the doctor or the clinician's consultation room, where the clinician can look you in the eye and not have to be working on a laptop or an iPad, and really have a quality interaction with you, because notes are being taken by the AI, and the person's informed up front, and then those notes come back and the doctor, the nurse, or others check it out. If we can help people understand that that can be a good thing toward their health, as long as that AI is trained in a way that an older person or any patient understands that, oh, that system hears me, that system understands me, that system is going to free that clinician up for a better engagement on my needs, it's a win-win. So that's an area that I'm very excited about. And then something else we see, again, seniors really engaging with technology and with information in a way that's meaningful to them. Last year we saw the passage of the cap and smoothing, part of the IRA, where we were able to say for those individuals who had cost sharing and really struggled with that early in the year cost sharing relative to all year long, we were able to create educational materials that help them understand that, hey, there's an option for you now. And they really embrace that. But we have to make sure that that communication is understood, and that groups like our membership, the patient organizations, are trusted and accessed to be a part of that messaging. Right. And I think that's really key in any of the things we're talking about.
I love that, where we have like the policy win. We just got to pull it through so that people actually understand it, right?
Know that it happened, yeah.
Right?
I mentioned earlier, well, first thing I'm going to say is when I saw this question, I made a whole list of bright spots. So
great.
there are lots of bright spots, which I will not talk about all of them, but I want to touch on two. One I mentioned earlier, which is in the oncology area, and some of you have heard me tell my personal story before. But I was diagnosed with breast cancer a few years ago, and my experience through that process was phenomenal, and it was because the system was working the way it's supposed to. I never had to worry about prior auth. I went in for each step of, whether it was my surgery or my radiation or my medication or whatever it was, and it was all set up. My surgeon set up all my appointments for me. I never had a problem with my health insurance. I never had to worry about any of it. Well, come to find out, since I've been in this job, that was because of a lot of things happening behind the scenes, some of it because of AI, some of it because of clinical care pathways, but just a lot of different things where health plans look at what is the standard treatment protocol for what kind of cancer I have. These are the things that are going to happen. So they went ahead and put in all the prior auths at the very beginning for the whole treatment process, however long it would be. And there was that relationship building among everyone. I was offered nutrition services. I was offered mental health counseling, all of these things without me having to worry about billing or anything else. So that is it's my personal story, but it's a story I hear every day, and it's an example of what we can scale up if everything's working the way it's supposed to. And the second example I want to talk about quickly, and it really applies in the BH space in particular, is telehealth. So I think we definitely saw that as one of the bright spots that came out of the pandemic, was that we saw just the potential of telehealth. And in behavioral health in particular, what we found is that a lot of patients were more willing to keep their appointments when it was a telehealth appointment, stuck with their treatment and their therapy in a way that they didn't do when it was in person pre-COVID. Were really able to integrate their care better. So that's just another bright spot. Again, I think I hope that before I either retire or die, that we can see the telehealth flexibilities that are extended every couple months being made permanent. I think, in the area of behavioral health in particular, we're seeing some of the providers not really completely changing their way of delivering service, and because that is temporary, and I think we could see a lot of change if that ever becomes permanent.
Plan for it, right? Certain
Plan for it.
Those are awesome. I'd build on what Randy mentioned at the outset about prior authorization. We have a role to balance the healthcare dollar that we all invest in our health coverage. We try to balance access and affordability for everyone, and prior authorization is a tool that we use to do that. We know it's not perfect. We know it can be improved, and what Randy mentioned was a commitment that the health insurance community came together to make some tangible, concrete commitments to improve that process, because we do know It can be frustrating for providers, frustrating for patients, but we've pledged to reduce the scope of prior authorization. We know it doesn't need to be applied at every single service, and many plans have actually been pulling back the scope for a number of years anyway. But that's one commitment. The second is just standardizing the process as much as we can. We understand that if 5 different plans with a provider have 5 different systems and 5 different lists, it's very cumbersome. So we're doing what we can to standardize that. Not letting it get in the middle of a care treatment plan. If one plan has approved a treatment, having that approval carry over to another plan when someone changes, like many of them, many folks are going to be doing in the next couple of months. And then lastly, making sure that we can do this in real time as to the greatest extent possible. We want to approve these in real time and modernize the process. That does take a partnership with providers. Less than half of all prior authorization requests are actually done electronically. Half of all requests are still done by fax and phone. And we desperately need to move into the 21st century. And so we want to approve these requests, but at the same time, they need to be submitted in real time in order to be approved in real time. So those are commitments that we came together to make, and we think that we'll make a pain point less so. One other thing I'd point to for a bright spot is a group called Civica. And Civica has been around for, I think, 10 or 12 years. It is a low-cost drug manufacturer. They produce everything from generics to drugs that are common but in short supply because they are so cheap. And BCBSA has a partnership with Civica Script to bring many of those products to the market through the pharmacy benefit. And one thing you'll see, I know we have a $55 box of insulin pens, which is literally at cost for long-acting insulin. And that is to get these medicines to people who need them, so cost isn't a barrier. And that is a real bright spot. I think Civica and Civica Script have a great story to tell and have a great path forward to bring those medications to people who need them at a price they can afford.
Those are all great. We are moving into our rapid fire. Our time went drastically down.
Wow, that did go fast.
That's your way of saying we're
So
talking
just time
too
check.
much?
We have about 4 minutes. I'm going to ask like rapid fire question. Our last 2 questions. The first one is, as you all know, the Alliance its history and its roots have always been about education, and particularly attuned to educating people who may be new to healthcare. So if you had a new staffer on the Hill, in one word, what is the issue you would get them focused on first in terms of their learning curve? David?
I would go affordability, 100%.
Great. Debbie?
Quality.
Randy?
Patient engagement.
Wow. Okay. All right.
That would be a great trifecta.
Yes, it
Right? That is the trifecta.
Yes.
So basically everything. Next question. What is an issue that is hot now but won't be hot in 26?
That won't be.
Won't be hot. And we're going to take anything off the table in 26, and you can say no.
I think broad expansion of coverage is not going to be on the table for 26.
Bold statement.
Can I flip the question and put what I think will be on the
Yeah,
table?
I mean, that was going to be your last question. But you can go right for it.
We'll just move there.
Okay, well, I wanted to make this point because we don't hear a lot about it right now, but I think we will hear more about it in the future, particularly next year, which is the No Surprises Act. It protects patients from balance bills, and I think that's a good thing. What it has done, though, is it's created this process called independent dispute resolution that, quite frankly, is just a broken process. And it's only been up for a year or two, and we just haven't seen it mature, and we haven't had any reforms to that. And we are committed, because we're so committed to affordability solutions, this process is actually driving costs higher. And so I think between the administration and Congress, there are things that we must do to fix that process, to make it more transparent, more accountable, and actually be a reasonable place to come to agreement between providers and payers that don't simply have all the pressure driving costs up. So that's one issue I know that we're going to be looking at very, very closely.
Great.
Say
Randy?
hopefully not on the table. There's a whole package of health provisions that are bipartisan, that have been well thought through, that just can't be brought forward. And wouldn't it be nice if this is the year that they can come forward in 2025, and then that will put to rest things like the extension of telehealth, the Safe Step Act that gets in much the same way we looked at challenges around prior authorization in areas of step therapy and things like that, that we have the knowledge and the commitment on the plan's part, the provider's part, the patient's part. And our breakthrough, I think hopefully won't be on the table, are some of the needless complexities and barriers in the red tape that really are holding back our ability to embrace 21st century medicine at the speed of discovery. And that would be great if we could just celebrate those wins at the end of this year. They're thought through, they've had support, they've come through different committee processes. I think they're consistent with the administration. Maybe that's it that we could set aside.
Debbie, anything you want to add to that?
Well, I definitely want to put telehealth on the list again, because I always do. Value-based care, I think, is something that could be on the table in some way, shape, or form. Maybe not in that, not using those words. I think those are probably the key ones. But yes, that bucket has been sitting there for a long time, and maybe we'll get it tackled in some way, shape, or form.
All right, I did think of one that I hope they won't be addressing next year.
All right.
The healthcare tax credit. I hope that we can actually address it in the next few weeks. That is a financial lifeline for so many Americans. And obviously it's been wrapped up in the shutdown politics and partisanship. But we hope that they can see their way to a bipartisan solution because so many people depend on that. It's the central affordability issue in healthcare right now. And we know that there are members on both sides of the aisle who want to find their way to a solution. So we hope that we can get there and take it off the table for next year.
Amen.
This has been an incredibly optimistic panel, and we did not just stare and talk about the problems. And I want to be the first to thank you all for your comments and your perspectives and supporting the Alliance. Before we close out, I just wanted to say next year is our 10-year anniversary of our Signature Series program, and we're going to be taking on the topic of healthcare payment. Where are we and where are we going? Everybody in this room has something to say and a perspective to that. So I hope that you're part of shaping next year's program with us. And so thank you all.
Thanks, Tanisha.
Thank you.